So I'm going to try to share the slide now. Okay. Today, we are going to try to look at maxillofacial injuries. And this slide just is trying to illustrate what happens in practice. You can see here is the components of the bone, and here you can see plates. These are plates which are used in what is called osteosynthesis when you are repairing fractures using internal fixation. So different types of plates, and of course, depending on the type of fractures. Well, in our setting, this is not so common because you know that these things are these plates are very costly. But this is the ideal which is supposed to be used. But we are going to look at the more practical approach. So in brief, we are going to be able to have knowledge and the skills which will be able to help us recognize life-threatening nature of facial injuries. For example, airway obstruction, associated head and spine injuries. Then how do we assess facial injuries and how do we make diagnosis, and some of the principles of management of facial injuries. Yeah, this is the osteology of the head, particularly the structures which are involved in the orofacial area. And you can see up the frontal bones, the nasal complex, the zygomatic complex, the maxillary complex, the mandibular bone. So yeah, so these are the structures you deal with when you are doing oral procedures or within dentistry. These are mainly the bones you actually deal with. And this is just a lateral view. Still the mandible, the maxilla, the zygomatic, the orbital, the nasal complex, the frontal, the parietal, okay, and the temporal, yeah, the occipital. So, yeah, possibly you, of course, now you will have to revise just the anatomy, of course, of the mandible. You know that the mandible has the body, it has the ramus, it has the condyle. Of course, the condyle has the neck, and so on. And then you'll be able to note that there are weak points along these structures and so on. Then here, of course, you have the maxillary complex. Of course, you know that the maxilla also bears dentition and the mandible the same. And you have already studied anatomy, knowing that in front here, you have your incisors, then you have your canine, then the premolars, the two premolars, the first and second, then the molars, the first, second, and third molars, both upper and lower. Yeah, so these are the structures we mainly deal with, and you know already why we need the teeth. Yeah, you know that the teeth are very important for the human being. Even other mammals, they are very important, particularly for the human beings. You know that other than for mastication, these give the facial profile, they give you a smile, and they are key in speech and so on and so on. This, I think, already Dr. Quizra has already taught you those things. So the causes of orofacial injuries can come from different sources, RTS, violence. Violence can be in any form. It can be maybe they hit you with a club, maybe they use a knife, or maybe it can be a gunshot wound or other things. It can be, you can be pushed and you fall, yeah. Then it can be from sports and other recreational activities. In sports, maybe you are running, you fall, you can get injuries. Or it's maybe like boxing, then your opponent gives you an uppercut, then you sustain injuries. Yeah. Or you are in a rugby, you know how those guys are. They can jump on you as they play their ball, the rugby ball, and then you sustain those fractures. So, and so on. The causes can be from many. I think these are the same causes of trauma, you know, already from general surgery. So they are really, really not different. They are the same. Yeah. Of course, not forgetting it can be also pathological. Yeah. The same causes of injuries, you know, in a general surgery, you just simply can apply them here and they will work. Injuries which are going to cause the fractures they can be categorized as high impact or low impact, depending on the part of the orofacial bones which are going to be involved. So the zygoma and nasal bones can easily be fractured with low impact force. Yeah, you can see that the nasal bones are the weakest, just 30 G is enough. And the zygoma, the zygomatic complex also is fairly weak. And the angle of the mandible is the next. The frontal bone follows the symphysis of the mandible, and then the supraorbital rim is a fairly robust one. It's the one which can sustain a higher force. Yeah. So the force which fractures the supraorbital bone will actually almost smash the rest of the facial and the maxillomandibular complexes into threads, if I can say. Yeah. So almost 60% of patients with severe facial trauma have a multi-system trauma and the potential for airway compromise. Yeah. Facial trauma, multi-system, because by the time you are going to get facial trauma, the possibilities that even you may be having injuries, sometimes maybe to the chest and other systems. Yeah, that is common knowledge. Those of you, I think all of you have already rotated in surgery. You know that patients will come with head injury, but they will also have trauma elsewhere. Maybe a fractured limb, maybe fractured ribs, and so on and so on. Yeah, so if that is said. So assessment, of course, the usual things, yeah. Looking at the Glasgow Coma scales and the injury severity scores and so on. So I think the clinic almost always, yeah, the Glasgow Coma scale is the commonest thing you use. You know, is this patient, can they respond when you call them? When you press them, can they respond? You know, so you know how to do those things very well. So I don't have to emphasize that, but just to remind you, what you already know to do in surgery is the same, because now when you are assessing a patient, that is just the basic knowledge you already have. Yeah. ABCDE in the triage of a casualty, yeah, the airway, with the cervical spine control is key, breathing and ventilation, circulation and hemorrhage control. There can be disability due to neurological deficit. Then things like exposure and environmental control. Yeah, so maybe just a point to note on C, hemorrhage control. You know that there can be injury intraoral. So sometimes you will be able to see, or you may not see that there is a bleeding. Okay, you may only see there is a bleeding if the patient spits, but if the patient doesn't spit and they are swallowing, then the next is maybe their stomach is full of blood and they're vomiting blood. Then that's when you will realize, hey, there's something, yeah. So that's why you need to be able to do oral examination to see, is your patient bleeding? No, intraoral, yes or no, yeah. The effects, injuries to the facial skeleton can be immediate or delayed. Immediate is immediate airway obstruction, and there can be delayed airway obstruction. So the immediate airway obstruction, what are the causes? I think last time I mentioned this to you already. Oh, no, not to your class. Maybe I was teaching another class, first aid. Then I was telling them that a person can get trauma and in the orophacial region, and maybe the teeth are dislodged. This always happens. And when they are dislodged, if you can't see those teeth outside, then that means they might have been inhaled or even swallowed. Okay? Yeah. So you need to really assess for that. Yeah, a person you might find they having poor breathing, and the underlying cause, a dislodged tooth is in the airways. So how will you know that maybe the tooth is in the airways? I think you guys will let me know shortly. Then there can be, excessive bleeding, clots forming, yeah, and excessive secretions. I don't know, maybe whenever there's blood in the mouth, it increases the secretion of the saliva and mucus. And so all this can compromise the airways. And when the patient is semi-conscious or unconscious, the one key thing is usually the failure to control their tongue. And this can obstruct the airways. I think this you already know about that. Yeah. So maybe before I proceed, let me check in the chat room. How are we going to know that, for example, there is a tooth in the airways? You can just post one. I'm waiting for the answer. Please, can you people post in the chat room and let me know? How are we going to know that? Okay. Difficulty in breathing, yes. I think we hear wheezing. Is that wheezing? Here, the other word, could that be wheezing? Yes, wheezing sounds. Yes, coughing. Yes, yes. Strider. What else? What else? Then how will you prove? How will you prove that there's a tooth in the airways? Those are now the signs and yes, but in equal lung expansion, it can be anything. Yeah, maybe the lung is collapsed, maybe it was traumatized due to a fractured rib. How are we going to prove? X-ray, good. Visual, no. Chest X-ray, yes. Yeah, yeah, chest X-ray, true. You'll be able to demonstrate. Fantastic. X-ray, CT, and so on and so on. Yeah. Good. So let me go back to the presentation. With that maneuver, how will it prove? It may be, I'm not sure. Yes, do direct laryngoscopy. Yes, that one, yes. Good. Yeah. So now we know there can be a tooth in the airways. Some of the signs you have already told us. Maybe the patient is wheezing and is having difficulty in breathing, maybe coughing continuously. But then how do you prove? You can do an X-ray, chest X-ray. You may do a laryngoscopy and so on and so on. Wonderful. Good. Where is my... Yes. So some of the emergency management of the airway control, you guys know this very well. Chin lift, jaw thrust, oropharyngeal, suctioning. But you know that sometimes our suctions are not working. Then the tongue, you have to move it forward. Yes, because the tongue, once the patient is not controlling it, it just likes falling backwards. Okay. And be careful with the cervical, vertebrae. it can always be traumatized further. Head injuries, orofacial injuries, you know the impact can always be sustained by the cervical vertebrae, and so it is almost always prone to what? Fracture itself. So you need to take care. Good enough, you guys are not anesthesiologists yet. I'm sure by the time you become one, you must always be conscious of patients who have suffered maybe orofacial injuries because of the risk of fracture of the base of the skull. And so when you attempt to intubate them, you might find that your tube may be inside the brain, and then don't complain who has killed the patient. Yeah. Yes. So you, as the doctor on site, also don't request for intranasal intubations, because that is a risk. You are going to push the tube into the base of the skull and cause injury to the brain, and so it's very dangerous. Because as we shall see, some of the fractures of the maxilla can expose the brain. So, yeah. So other forms of intubation may be better. Yes, fiber optics intubation, if it's available, of course, that is the best, because you are able to see what you are doing. Yeah. Yeah. Percutaneous tracheal ventilation and retrograde intubation, cricothyroidectomies, and so on might be the better options. Hemorrhage, yes, there is once the injury is tearing through the soft tissues, there is almost always going to be bleeding to the oral cavities. So, and maybe through the nose. Yeah, so direct pressure, yes, that is what you are going to do. Then blind clamping may be risky. You can cause more trauma, so you avoid that. Try to clear the site of any excessive blood clots and or maybe direct bleeding, and then you see where the blood is coming from. And yeah, you may be able to clamp a bleeding vessel when you are able to see. If you don't, you clamp blindly, you miss it, then the bleeding continues, or you cause damage to other structures, which is not necessary. Then for the nasal bleeding, direct pressure, of course, anterior and posterior parking. I'm sure you have learned this in ENT, yeah, and please, that is the key. You need to learn those skills so that you know how to prevent continuous bleeding. Then there's the pharyngeal bleeding, parting of the pharynx around the endotracheal tube, yeah, can also reduce that bleeding. Then history is key. Yeah, history is key. Get the history from the patient if they are awake, if they are conscious. You get history from them. Get from the witnesses or the emergency services. Then you want to know, was there loss of consciousness? If so, how long? Yeah. Are they able to see? Are they able to see very well, or somehow are they able to hear? Okay, or there is loss of hearing. So these are already going to give you some insight of what is happening to your patient. When they move their eye right, left, eye movement, up, down, are they experiencing pain? Yeah. Simple things, but I think you guys have already done ophthalmology, so facial injuries can sometimes impact the eyeball. Yeah. Yeah. So are they experiencing numbness, tingling sensations in the face? And when you ask them to close their jaws, okay, which is usually simple, you just ask them, can you bite your jaws? Okay, maybe you first ask them to close their mouth, and then secondly, tell them, please bite your teeth together. Just simple instructions, okay? Then they are going to tell you that I'm not able to close my mouth, okay? And so when a person cannot close their mouth, that means there is a problem with either the muscles or the bones. Okay. So when do they experience the pain? Is it when they are trying to close or when they are trying to open? So then it will give you an idea. Okay. Yeah, so the standard approach, of clinical examination is what we do. Yeah, when you do visual, you see your patient. That's why you need your eyes working, so that you are able to see. Now, like this guy here, you can already see that this guy has a problem. This other eye, okay, is open, but you can see some bit of edema here. And this other eye, he cannot open. There's not only edema, but there's some bit of bleeding you can see. Then there seems to be some laceration here, some blood clots, around the lips. So you can already see that there is some sign of trauma. Okay, this is just visual examination of the extraoral, and also you can ask them, can you open the mouth? Yes. Then you can also do intraoral, just visual examination. They may or not be able to open their mouth, but even if they are not able to open their mouth, then you are able to see maybe some blood clots or blood stains around the lip or on the tongue. Then you can know that there is also what? Some evidence of trauma intraorally. Okay. So you want to also visually see if there is evidence of facial asymmetry. Does the face side on the right, is it similar to the left? Okay. You might find that there is a tilt in the facial profile. Okay. The right side may be elongated and the left side may be shorter. So that is already a sign of asymmetry. So it means that the body generally is usually symmetrical. So any distortion creates asymmetry. Yeah. Then you can now maybe do other assessments. Maybe you want to assess the eyes, okay? Are the eyes moving uniformly in the same direction, up, down, okay? Because you can always want to know, you can ask them to look on the left side or on the right side. So are the eyeballs moving the same? Can they both move in the same direction? Or one is fixed and is on one moving? Are they able to move up and down? Very key. These are just simple things, but they are going to reveal for you a lot of information. Like simply asking, can you open your mouth? Can you close? Can you move the jaw, the lower jaw, right and left? You know, simple things. And then, of course, after the visual assessment of everything, inspection, okay, then you can palpate. Yeah. Yes, so here you are checking the intraocular region. Yeah, this is assessing the intraocular region. Then you could also assess the supraocular region. Then you can assess the zygomatic area, okay? Then the nasal framework and the maxillary area, okay? And the mandibles, both the symphysis, the body, and the ascending ramal area, the ramus. Yeah. So this clinician here is checking, the premaxillar area, and you see is checking this part to see, and also deep in the retromolar area, and also maybe you can also here, using this intraoral assessment, you want to check the zygomatic arch, because you can fix here and you'll be able to feel. In case it is displaced, then it will be closer. It may be closer somewhere, but the normal one will be a little bit distant. So you can see, is there a distortion in the margin of the maxillary complex? Yeah, it is supposed to be continuous from the infraocular rim to the zygomatic arch. But if you find a distortion, because the one side may be normal and the other side may not be normal. Yeah. So I think I've already highlighted all these issues, but maybe what I've not talked about, maybe in open wounds, there can be foreign bodies. The foreign bodies can be anything. I think if you have ever seen a patient who has been involved in an accident, let's say in a border accident, they fell on not maybe on the tarmac, but let's say they fell somewhere on the Maram Road. Then the wound can have anything. It can have sticks, it can have stones, it can have gravels, it can have even pieces of the person's own bone, yeah? And if it is in the orofacial area, it can have even the teeth impacted inside the soft tissue. So the FBs, please take care of foreign bodies in the soft tissue, because when foreign bodies remain in the soft tissue, they are going to be source of chronic injury. And that part, it may heal temporarily, but another time in the future, then you will find that the foreign body, the body rejects it, and it can cause other problems. Yeah, you have learned those things in pathology. So don't forget your pathology. Foreign body in a tissue will always be a foreign body. So the body will try to reject it. Yeah. So, of course, just maybe here, when you are, of course, doing an assessment, particularly when we are palpating, don't ignore, don't hurry. Be systematic from extraorally to intraorally. Be systematic, pay attention. Yeah, look at the bone outlines. Compare right side with the left side. Yeah, because one side almost always will tend to be more normal. So it will give you a guide that the other side is a problem. Yeah. Yeah, so the nose is almost always a quick culprit. You see, the bones of the nose are very, very fragile. They are paper thin, so they are fond of fracturing. Even in the slightest force can always dislodge them. I used to have friends who were Bazungu, and I used to tease them that for them, because their nose is too long, that's why it is always fond of fracturing. But even a black man's nose can fracture. So don't take my word. The most important thing is that the nose has really weak bones, and they are prone to fracture when there is direct force on them. So when the person has a orofacial trauma, please pay attention to the nose. The nose can tell you a lot of stories of what is happening to the person. Yeah. You can see that sometimes the nasal septum can bend on one side, then you know there is a problem. Or you can see bleeding. There can be real blood, or it can be mixed with what? Cerebrospinal fluid. And I know you guys know how the cerebrospinal fluid looks like. So let me just confirm in the chat room, please, you post for me how the CSF looks like. There are some posts here, but I will go to them later. But I first want you to post for me how CSF looks like, so that I'm very sure that you know how it looks like. I'm waiting in the chat room. In the chat room, I'm waiting. Only two people, Mohumza and who? Elias. Elias is Apangana. Richard. How come only 319? Where are the rest? Please post, because I have to be 100% sure. Okay. So, basically, I think, yes, so you guys have posted. Thank you, not everybody. Yeah, it would have been good if everybody posted instantly, because this is something which you should be knowing off head by now. You did the third year. You have, I'm sure you have seen them aspirating the CSF in meningitis, and so yeah, when it is not infected, it should be clear, obviously. It should be clear. Yeah, when it's not infected. But when it's infected, or when it is mixed with the blood, then it will have some bit of staining. But Yeah, when it's infected, of course, in meningitis, that's another story. But in a normal person, it should be what? It should be clear. Yeah. So just now to remind yourselves, CSF, you will know that there's CSF when you see a clear liquid leaking. Yeah. After such a trauma through the nose, and yet maybe, yeah, sometimes it leaks, and then maybe the person can experience it like a salty, you know, leakage in their throat. Yeah. Good. Yeah, so you palpate. I think all those structures, even the nose, when you are going to palpate the maxilla, the mandible, bone moving over bone, you will always hear crackers. And you will see deformity. And you will see dislocation and so on and so on. Yes, so you have to assess the sarcoma, the zygomatic arch. This one for the zygomatic arch, it is very simple. When it is fractured, many times you see the side which is fractured is flattened. So already that can solve for you something. If the person you are just seeing them face to face, they are facing you and you are facing them, you will see that one side of the face is already flattened. Then you know that the zygomatic arch is probably already gone. Yeah, it is a fracture. Yeah. So then you can just palpate. If you do by manual kind of palpation, your hand is on the left side of the arch and the other hand is on the right side of the zygomatic arch. Then you will already know as you move your hand, maybe from the middle side to the lateral aspect, one side, which is fractured, will definitely show distortion, and the other one will be normal. It will be continuous. So you also check for facial stability, okay? Particularly the maxilla. It's very simple. You just hold the maxilla on with your both hands in between the thumb and the finger, and then you just try to move it around a little bit. If there is a fracture, you will actually see the maxilla moving. Yeah. So depending on the different level of fracture, which we are going to look shortly, then you will see maybe only the teeth are moving or the whole fracture, the whole maxilla is moving. So it will depend where the fracture is. Yeah. Then there's what we call malocclusion. I don't know whether there's any part of the body which occludes, but I think it is on the teeth which occlude. So malocclusion, this is supposed to be normal occlusion. Normal occlusion is what you have if you have never had a fractured mandible, or if your teeth are normal. When you bite, that is normal occlusion. Okay, there may be other deformities, maybe due to orthodontic problems. Maybe the teeth have not grown normally, particularly the anteriors. They can cause some malocclusion. But if you have normal bite, normal teeth arrangement, then it should be normal occlusion. But also, you could have been having your own malocclusion, But then within that malocclusion, when you get an accident, then you will realize there is another problem. Yeah, you can't bring the teeth together and so on. So a person who has been having normal occlusion, now they cannot bite. That's malocclusion. Then there's the plating, then there's a step off. Yeah, a deformity. Step off is like a deformity. Yeah. So yeah, when you do intraoral examination, you can check each teeth by doing individually, because you may make assumptions, then you find a tooth, a single tooth which was involved in the trauma. Maybe the force landed on it, it may be dislodged, it may be mobile, or even it may be fractured. Yeah, so it helps to just simply run your gloved hands on the teeth. But of course, you have to be careful. You first look before you do that, because there may be obviously fractured teeth, and those ones can cut. They are very sharp, of course, you know. The enamel, you know, when it is fractured, it can be very sharp. So you first inspect with your eye before you touch with your fingers. Yeah. So here is, of course, an example of a fracture of the mandible, and you can see that it is. Can somebody tell me? Okay, all of you, can you post in the chat room? Where is this fracture? Okay, which teeth are involved in this fracture? Let me go to the chat room to be sure that you guys learned the dental anatomy, which was taught for you by Dr. Questa. The fracture line is where Arenda man is correct up to this point. Now, Richard, that is correct, because it is in between. It is not on one tooth. It is in between 4.2 and 4.3. And can somebody tell me why possibly that could be the case? Now, also Adson, yeah, that is very correct. Yeah, 4.2 and 4.3, that's where it is. So now, can you guys try to explain briefly why does the fracture happen to be there? What could be the reason for that fracture to be there? And by the way, that is a common site of these fractures. So what could explain? Yes, Nathan, that is correct. And so why do we have that fracture there? Post in the chat room. Please post in the chat room. The force is applied on the left lower jaw. Maybe it is true. What else? Miro, now you have said the right thing. A weakness at that point. So what is the cause of that weakness? Where does that weakness come from? It is not only Miro to answer, it is for everybody. Where are the answers? Please type very fast, like you always type for your friends on WhatsApp. Why is that weakness? Where does that weakness come from? What is the source? Osteoporosis, you can see that this is a young fellow. Can't you see these teeth are for a youngster? Okay, maybe osteoporosis, maybe it could have been due to but this guy looks to be very healthy even when you see the teeth. So I don't think it was osteoporosis. Injury, infection, no. There's no sign of infection on this guy. You can see that the mucosa is very normal. Yeah, so and those teeth look normal, except this, the central incisor, the upper 2-1, I think was fractured also in this accident. Other than that, really, this guy is really more or less very normal in everything. The separation between the different, that space, not necessarily anatomical weakness, yes. So what is the point of, well, the curve, not really. It is an anatomical weakness. And why so? Please explain. It is an anatomical weakness, I do agree. So what is the source of that anatomical weakness? It is not the curve of the mandible. That is really not it could be, but not the main one. It's not a congenital anomaly, not at all. It's an anatomical weakness. Yes, I agree. Okay, but now, okay, maybe to cut the long story short, if you guys can see, let me now go back to the slide. You can see which tooth is this? Which tooth is this? Pardon?
Yes, doctor.
Which tooth is that one?
Canine.
Canine, yes. What do you know about the canine?
They are for tearing.
Yes. I didn't. Okay. I asked a bad question. If structurally, what do you know about the canine? What is unique about the structure of the canine?
They don't have cusps. They have one root, and they.
Okay. In relation to this fracture, now I'm saying that the canine is responsible for creating that point of weakness. Yes? And so what is it about the canine that has made that point of weakness?
Is it because it has a single root?
Let me see in the single root, subtip pointed as a single root. No, those I'm not, I don't agree with all those answers. Now, one good answer from Nathan, that probably because the root is very long. That is one point. Then, what other point do you add? Hello?
Yes, doctor.
Yes. Long root is one, because I think it is virtually the tooth which has the longest root in the human dentition, right? You guys are the ones who learned this thing recently. What else? Okay, now let me just cut the long story short. It is true, this point of weakness is a result of the presence of this canine. Canines have very long roots, and not only are they long, but they are also very large. That root of the canine is very big. And so the bone here tends to be, the bone mass then is quite compromised. And that in a way creates a point of weakness. Yeah, so these areas here are always one of the prone ones. And then here we are going to look at that. Yeah, good. Now, when you do intraoral examination, this is what I was telling you last time. Last time I was telling you these points. You can see that this is an obvious fracture now. So I guess any of you who is going to see a patient who is involved in RTA and has some orophacial involvement, you want to look at all the teeth. Now this one, you can see, this is a sign of a fracture. And now, when this guy got this impact, and so you can see that these teeth banged either on this, but possibly they may have not, they are intact, or he hit something which already fractured this, yeah, and caused this fracture. This may not be the only fracture. So you want to check the mandible through and through. There may be other fractures, multiple fractures. Yeah. And check the teeth individually. You see this tooth, it might have been displaced slightly inward, palatally, the way it is even looking. Yeah. So it may move with the bone, so it may not be loose on its own, but because moving with the big chunk of the bone, it might be displaced palatally, the way it looks. Yeah. Then check for lacerations. This is my important, because I'm sure you are going to easily see these fractures, but lacerations in the mouth can be very tricky. Now, the most notorious lacerations are in this vestibular area, okay? Vestibular area, very, very notorious. There may be no fracture here, or there may be a fracture and maybe with minimal tear here, and you just overlook, but this part of the vestibular area, you must always check. And it is so simple. Your gloved hands, just hold the lip, pull it away, okay? And then inspect the vestibular area. Because sometimes the impact is from this side of the chin or from the side of the cheek, and it kind of balloons the tissues here. You know, there's a lot of spaces in these padded areas, and that just tears off, this mucosa. And when you miss it, then that is going to be a source of problem, because food is going to start impacting that space deep inside here. Then after a few days, then you just see a lot of swelling. Then you will wonder why your patient is complicating, yet you are treating them. But you have not identified a point of entry for food, bacteria, all sorts of things which will be going into the that space. So always you must check when you see that patient has facial injury, check for this space. Okay, and also here below the tongue, I've also seen the tears there. I don't know how they happen, but they also happen. So please, you check, you ask them, if the person is able to open the mouth, you ask them to lift up their tongue. Then you check below the tongue to see that everything is in that. Good. So the fractures, can be of the mandible and also of the maxilla. Okay. And so, yeah, so the middle component of the face, you see these ones, and here we call those ones Lefort fractures. Then there can be fractures which can be up here. Then of course, the mandible, you see this is a panorales. What is this one where I'm pointing here? Can just to remind you of your anatomy you did in year 1 and year 2. I want to see in the chat room, what is this I'm pointing here? Let me check in the chat room to be 100% sure that you guys did the anatomy very well. And that is Mulunchi sings. Alveolar foramen, mental foramen. Yes, mental foramen. So, mental foramen is this point, and you are also going to see when it comes to fractures that itself it can also be what? A problem. So I'm sure you guys, when people have head injury, and now that you have done at least an introduction to dental health, now you should be better than all your colleagues in knowing that you need to make the right requests for investigation after you have assessed your patient very well. Okay, now you have the knowledge, and I'm sure with the practice, you are also going to gain the skills. Yeah, you are going to gain the skills. Yes, so when it comes to radiographs, different requests is what we call the Waters view, Caldwell, lateral oblique, and so on and so on. And of course, you can also do CT scans. Yeah. Of course, the best CTs for maxillofacial procedures is what they call cone beam. But now we, in our setting, because you see, we only depend on what is available. The normal CTs can actually work because they will do for you the basic of what you are requesting for. So with the CT, you are able to see the sinuses. You know, you can chop at different levels and be able to see, for example, trauma here. Yeah, trauma, maybe some other sign of trauma. Okay. Yeah, so and it can also help you to rule out intracranial clots. Yeah, yeah. CTs are very good. They will give you the, you know, good diagnostic tools. So there's what we call the nasal ethmoidal fractures. You can see this yellow paint, or the one which is illustrated here on this model. This is a CT model. Yeah, after CT scanning, the radiologists can, you know that they can always do a model which you can put on your computer, and it can give you a clearer picture of what is actually happening. So this is this structure here. Yeah. So fractures that can extend into the nose through the ethmoid bones, they are associated with lacrimal disruption and dural tears, and you can suspect if there is trauma to the nose or the medial orbit. Yeah, and the patients also can complain of eye movement. You see, the eye can be trapped. The muscles which move the eye can be trapped in a fracture line. And so then it becomes a problem for the patient to move the eye. So some of the clinical findings in this kind of fractures, you have a flattened nasal bridge, then widening of the nasal bridge, CSF rhinorrhea or epistaxis, tenderness, crepitus, and mobility of the nasal complex. Then when you do intranasal palpation, it reveals movement of the middle canthus. Yeah, so this the 3D reconstruction from CT scans of these nasal structures. So the naso-opto-ethmoidal fractures about 3 different types. Type 1, large fragment of medial orbit, medial canto. Here, the medial canto insertion is in that. Then type 2, there's a combination of the bones. The fracture line does not extend into the area of the medial canto insertion. Then type 3, there's a combination of the bones. The fracture line extends into area of the medial canto insertion. Yeah. So in terms of management, you need to examine and determine the extent of the injury. Yeah. So you look at the nasal bone, opto and ethmoidal bones, frontal bone, and see whether there is extensive or no damage. Then where there are wounds, you do debridement and close of the open wounds. Then you do reduction and stabilization of the bone fractures. So sometimes the canthus can be detached. So how will you know there's the increase in intercanthal distance? Just like this example here. This, of course, is not normal. You see the normal one is here, but this one you can see from here to here. Yeah, it is extended, so it's not normal. And even I can see here, the zygomatic process seems to be damaged. If you compare it with this side, yeah, here looks normal, but here, this is the kind of flattening I was talking about. You see, it is flattened here, but here it is normal. So, these kind of things are seen in connection with the nasal bone injuries, nasal ethmoidal fractures, the foot fractures. Of course, not all the foot fractures. Yeah, in the foot 1, that will not happen. But when you are talking of maybe the foot 3, and maybe 2, but mostly the foot 3, obviously, it can happen. Yeah, I don't expect you to do too much of this, but in the management, of course, by an experienced person, or when you guys gain more skills, particularly when you have done maybe plastic surgery, or when you have done maxillofacial surgery, when you guys are more mature, then some of these things you'll be able to do them. Transnasal wiring techniques, then also cantoplexy, identification of the ligament, liberation of the, yeah, this one, ENT, not ENTs, but ophthalmologists. Yeah, this is what they actually do, a lot of it. Yeah. But for the bone, that one, a maxillofacial surgeon can do those things. Yeah. And the nasal complex, the ENT, they can work on that. So here, sometimes you need small structure, but you might need what they call multidisciplinary teams, to bring the best outcome. Here, you see a very small structure. How many specialties? 1, 2, 3, even maybe 4, if you add the anesthesiologist, and maybe even sometimes 5 if you add the neurosurgeon, particularly when you are now beginning to involve the base of the what? Skull. Yeah. So I think I've been talking a lot about the zygomatic complex. This is really a very key structure of the facial bones. And yeah, we can just maybe go through it quickly because I've been really emphasizing it a lot. In terms of anatomy, I think you already know it very well, but just a reminder, star shape, okay, star, you see? Let's see the star shape. We did the 4 processes, which are the frontal, temporal, yeah, the buttress, then the orbital floor, yeah, this one. This is the orbital ring, but this, you see the orbital, the infraorbital ring has these 2 components here. From the orbital floor itself, and this one which is coming from the what? The zygomatic process. Yeah, so, and you can see that there's a point of weakness here. And there's a point of weakness here. A point of weakness. So that's why this bone is really, it is kind of like hanging, if I may say. So the temporal fossa and the muscles, the muscles which are attaching the temporal bone. The massetas, which will also do their job. Yeah, and we'll pull it down when, that's how it always ends up filling this space, because these massetas, they are very strong muscles. Yeah, just the anatomy reminder, you can see the orbital floor, those bones which are, yeah, there. Yeah, so the key point here is that the zygomatic bone fracture is a block, because the rest of the bone is really strong, though the weakness comes from the way it attaches its processes to the neighboring bones. Yeah, as you have seen already. So those points act as weak points, and then they make the whole complex to be fragile. Yeah. I think those of you, okay, this is because this person is not black. If in the black people, you will see, that when there's a chymosis, it looks purplish. Yeah. Not so much reddish like this, but to look more purplish. And I already told you, like the flattening, yeah, the zygomatic arch. Of course, pain and tenderness, but even there can be difficulty in opening, particularly if it is a big fracture and this bone is displaced downwards, then you start finding that opening the jaw becomes a challenge. The mandible its space for opening becomes limited. Yeah, because the ramus will get locked onto this and then it doesn't want to open. Of course, deformity, that one you can also see. Yeah, like here, if you can see this one, yeah, this is what? This is deformity. Yeah, this is not normal. And of course, you can maybe sometimes see deformity here in the octal ring. And this is simple. You also just palpate. Like I had already shown you how to examine. Yeah, when you're examining here, so this is the right side. So you are examining them, maybe you are from the posterior behind them. And so your right fingers will be assessing this. Then the left fingers will also be assessing this. Because you move along the margin to see is there any discontinuity, yeah, in the outline. Yeah. In the chat room, I just want somebody to tell me what trismus is. Let me check in the chat room. What is the trismus? Just one message, two. Okay, reduced jaw opening, good. Lockjaw, yes, that is correct, trismus, yeah. So the causes of trismus can be many, but in the event of accident, when there is an injury to the jaw bones, and even the zygomatic process, there is always possibility of getting what? Trismus. Yeah, that's okay. Here, I just want to I think you are familiar with this, subconjunctival ecchymosis. This, particularly when you get some of the left foot fractures, maybe particularly like left foot 3, you will find bleeding in the octal ball. Yeah. So sometimes this actually happens. Emphysemas can happen because there's a lot of subcutaneous spaces which can easily be pumped with air, and then when you touch, you really can hear those crepitations. Yeah. Unequal pupillary levels, yes, when there's a discontinuity, when there's a fracture on one side, then you don't expect the eyeballs to be at the same level. Yeah, so all this, I think from surgery, you already know all this. So these are just things you need to look out for. It's a key. So you see these kind of things in a trauma patient with the orophacial injury, then you can already begin to suspect there could be a problem. Then you know that you need to make the right word, request for investigations. Yeah, I saw some discussions now in the chat room. Yeah, patients with multiple traumas. Where is the dentist? You know where the dentist will be, where the general surgeon cannot manage. That's where the dentist will begin. Maybe I think that should be the answer. These are some of the different radiograph you can request. Now the Waters view, you can see what it is going to give for you. Yeah. So here you'll be able to, oh, where's my cursor? Here you see, you'll be able to see the octo rims very well, the nasal, septal bones very well, these sinuses, yeah, and some components of the maxilla, you're going to see them, and a little bit of the mandible. So this is a good request, you know, to give you a snapshot of what is happening in the orophacial region. So this one has a kind of like an open mandible. So you can see it's already going to give you a good outline of the mandibular bone. And also the zygomatic arches. If there was a problem with them, then you can be able to see that there's a problem. So maybe you could make also CT scans, coronal sections, axial sections. So yeah, CT, but in particular when they do a reconstruction, it will really give you a good picture. Yeah, you can see the points of weakness, yeah, and the points of weakness. And here is just a schematic of how this fracture looks like. Yeah. And this is how it actually detaches. Then it will drop, because to be pulled by the muscles, then when the mandible, which is supposed to be articulating here, attempts to open, then it will lock on it, or when it is already in the open position, you try to close, then it will also hit this component, then it will refuse to close. So then you will find that either opening or closing just becomes what? A problem. Yeah, because you can see here the rammers and these processes. Yeah. So fractures and the treatment, of course, you know that fractures must be either fixed or reduced and fixed, whichever. That is the standard procedure There is no other way. There is no other way of managing fractures other than reducing them and fixing them. So how you reduce and fix may be different, but the principle just remains like that. So you must reduce and fix the fractures. And earlier I shown for you that when you have the resources, you can do open reduction and fixations with those plates. But sometimes you can use wires. There are some special surgical wires, which we use a lot in dentistry. And of course, the earlier the better, because you know that the body usually starts healing after trauma, you know. So you don't want it to heal in the wrong place, and you want the procedures to be early as possible. And the most important thing is just to control edema. And once you're able to control edema, then you are able to do your fracture reduction and fixation. Yeah. So this is for the zygomatic arch fractures. Yeah, so there are two approaches. One, you can actually just open intraorally a small slit in the sulcus and fix a special plate, a blade, which you use for raising this, and you then can always go back to place, but then you advise the patients not to lie on that side, because when they do, they're going to press it back. Yeah, but also maybe using the open reduction, you make an incision here, open it up, and then you're able to see and fix and in these points on these jaws using plates. Yeah. Okay. So this is where you can always do these incisions, because when you open this incision here, when it heals, it can actually not be seen, and then you are able to retract and be able to see. Of course, you have to be careful. There's below here. Remember the exit for the neurovascular bundle. So you have to be aware of that. So yes, I saw in the chat room some of you are complaining when I say that you are still young, or when you are not yet mature. I'm not talking maturity in terms of your physical age, but maturity in terms of the profession, in terms of the skills, in terms of the knowledge. You know, this you continue to build this, you continue to learn. When you finish your undergraduate, in postgraduate, when you continue to study, you learn always more things. Yeah, you keep adding and adding. That is the maturity I'm talking about. I was not talking about in terms of, I think in Uganda, anybody who's 18 and above is considered to be mature. But yeah, so I hope you don't get annoyed with me for saying that you are not yet mature. Yeah, so these are just good slides to show for you where the fixation is usually done. I think I had already shown for you some time before. So these plates, of course, to stabilize the fracture lines. So if there's a fracture here, now you are going to fix it here. If there's a fracture here, you're going to fix it here. But the fracture here usually is, tend to be in line with another fracture here. So that means you are going to have to put two plates, one here, then another one here. Then, of course, when this nasal bones fracture, this is like in a Lefort 2. When there's a Lefort 2 fracture, we are going to look at them just in a short while. The fracture line tends to be here. So this part of the maxilla detached from that part. And then, so you want to fix it. So you fix it here and also here. Yeah. So this is this is a temporary intermaxillary fixation. Now I'm going to be talking about it in a short while. This is what we usually do in our setting, because I told you that these plates are not necessarily cheap, and even our hospital here doesn't have the equipment for this. So yeah, many times what we do, we use just the intermaxillary fixation. And this, when I was talking about occlusion, this is occlusion. You want to achieve the normal occlusion. Yeah, this is a normal occlusion. This is normal occlusion. And so the maxillary teeth align on the mandibular teeth in the occlusal plane. So the occlusal plane is this one. That means they are completely balanced on this side and on that side, and even the posterior and the anterior are completely balanced. So when that you achieve that occlusal, normal occlusion, then you fix with eyelet wires to keep them stable. And so even when you are doing this internal fixation, you need to do this. If you don't do this, then you may not be able to achieve good fixation of the bones. Yeah, so this is always done before you fix using these plates. Yeah. Yeah, so do fractures of the zygoma happen on themselves? Yes. Many times. You know, when guys are fighting, they always like punching people around these ends because they want to teach them a proper lesson. So these kind of fractures are very, they happen there. Yeah. Or even when you fall, you know, you fall on your face. This happens. Yeah. So, and I told you how you are going to recognize them. You see flattening of that side. That's very simple. When you look at the person face to face, you see one side is flattened, and that is it. Then maxillary fractures, are they common? The answer is yes. But passengers, people fight, and so on and so on. Motor vehicle accident, yes, this happens a lot. You are not using seatbelt, this is going to happen. So, in that respect, these fractures of the maxilla were well described by a guy called Lefort. And so we have Lefort 1, Lefort 2, and its other variants, and Lefort 3. So broadly, we just care about Lefort 1, Lefort 2, and what? Lefort 3. How do you know it's a Lefort 1? How do you know it's a Lefort 2? How do you know it's a Lefort 3? That is the most important thing, which I want you people to pay attention to, so that when you see the patient in the accident and emergency department, then you will already know that this person has a Lefort 1, and you know that will need the attention of the dentist to support their full recovery. So, in terms of definition, these are horizontal fractures of the maxilla, okay, at the level of the nasal fossa, the 41. And so when you have the 41, if you held this teeth, let's say bilaterally, one with your hands on this side and this side, and you are able to actually tilt, and you will see that these components can move. You can tilt them like this, and or move them forward, backwards. Very simple. Then you know you are dealing with it. And they will move as a unit. Okay, but sometimes there can be a hemi-fracture here, hemi-maxillary, kind of like hemi-maxillary. And then, because this is also a point of weakness, sometimes if the impact is on this side more, this side may remain intact, and this side may be the only one which is detached. Because these fractures involve detach the maxilla and the bone of the palate as well. And so you find that it can be on this side, okay, one side, when this other side is what? Fixed. So you will see facial edema, malocclusion, I already talked to you about this, and the mobility of the maxilla. Okay. And in the 41, the nasal bridge is stable. So you find that the bones of the nose are attached to the what? The mid face and the upper part of the frontal of the face. Yeah. So in other injuries, you get what we call a L42. Its core characteristic is it's a pyramidal fracture. It is like a pyramid. You can see that there's an apex and there's a base. This is the base of the pyramid. This is the apex of the what? Pyramid. So this is, it detaches the mid face. This is what we call the mid face. Okay, it's entirely detached. The 41 detaches on the maxilla here. The 42, the what? The mid face. And it's a pyramidal. You can see the pyramid. Okay. So there will be mouth edema, there can be nasal flattening, and we already talked about the telecanthus, which you can see is displaced. Then epistaxis and CSF leakage. Then the upper jaw, mobility, and because when you hold here, then you can move like this, then you see things moving. This can be moving like this. You can pull here, but you will see movement around this ends. So then you can know you are already dealing with what? L42. Then we have got L43. This is the most dangerous because you can see L43 where it is passing. This is where fractures of the skull of the base are very common. Yeah, because this will extend right to the base. Okay, so the maxilla is involved, the zygomatic arch is involved, nasal bone is involved, ethmoid bone is involved, base of skull, is involved. So this is a very big fracture. Clinically, you will find what they call the disc-first deformity. Of course, the usual culprits, stasis, CSF, rhinorrhea, mobility of the maxilla, nasal bone, sarcoma, and the risk of airway obstruction. Yeah. Of course, these conditions don't read books, but because sometimes depending on the force and the direction of the force, there can be a combination of these fractures. So don't expect it to look exactly the way it is supposed to be, but I think the principles are the most important. So some scans. So closed reduction is with what we call intermaxillary fixation is what I was showing for you. And then there can be open reduction. And there can also be, open reduction can be using wiring. I've done this before. Or we can use the main plates, which I showed for you. Yeah. The only, of course, the main plates are the really do. That is the latest in practice. But where you don't have these wires, they are relatively more available. With the training, person can know how to use them. Yeah. So sometimes these traumas, of course, can affect even the injury, which may involve the eyeball, and the impact can even go maybe causing fractures on the floor of the opto structures. And as you can see here, you can get a comminuted, fracture of the floor. Yeah. And that means you are talking of components from the maxillary bone, zygomatic bone, okay, and the ethmoid bone. Yeah. So, but those parts, on the floor of the orbit are really fragile. They are not robust. They are not like this one at the rim. Those are very weak, paper thin bones. I think when you are doing anatomy, you already know that. So ecchymosis, subconjunctival ecchymosis, for sure, I should be able to solve for you that there's a problem. Then diplopia and the ophthalmos and so on, able to solve for you just from your clinical assessment. Yeah, small defects, you can conservatively treat just the things which can be treated. Sometimes they actually do resolve, but when it's big, then there may be really need for surgical intervention, repair, and reconstruct. Yeah, so different approaches. I'm more familiar with this, but there can be other approaches. I think this is a more complicated approach, but this is what I'm used to, because we have been using this in plastic and reconstructive surgery to do some corrections when the eyelids have problems. And so, and also some congenital problems, which are involving maybe the nose and so on, with sometimes, because this is a very easy access route. And even here, you can just open here and be able to lift the eye a little bit, and you are able to see the floor. And you can be able to put there a plate, and you are done, you are out. So, yeah. So, I'm more proficient or more aware of this than this one. But the people use different techniques, yeah, depending on their training and their preference. Yeah. Yeah, so this is what I was telling you. So when you make an incision here, and then you are able to lift this eye a little bit, then you are able to see the, you are able to reconstruct it. So it's really not so much of a problem. Yeah, this is a mess. This is a mess. They can use the titanium. Yeah, this can be used to correct defects. Yeah, I've seen a certain professor in one of the hospitals in Germany. He was actually the inventor of this. I was quite blessed to see him. And this is this technology is not very old. Maybe it is just the past, maybe about past 15 years when it was being invented. Yeah, you know the property of titanium. Okay, let me check in the chat room why titanium is really a very good material to use here. That should be from your jaw surgery again, orthopedics. Why do we use? Oh, the students have fallen off. Let me see. No, we still have 21 students. I know. Let me see. There is a question. There's okay. If there are questions there, but there is also a concern. So there's a concern from Robert, who is saying that there will only be 2 students, Pate and Mulonji. Well, now that one, I'm not going to do anything much about it. But there was a concern up there, a question about the lecture itself. And why titanium? Somebody says it's corrosive resistant. I think it is radiostable, natural titanium is a high tensile strength. Okay, I can. Now what I'm going to do, I'm going to leave this question to you, please. You guys are going to answer that. Because I can see, and it's a good hard tissue combat. Okay, yes. Tissue compatibility is one of its characteristics. That is correct. So that means the body does not reject titanium easily, and then it has a certain unique characteristic what we call osteointegration. So titanium is able to integrate with bone, and it will be as if they are really natural soulmates, if I may use that layman's term. you know, a bone and titanium, they are just like one and the same. Yeah. Yes, it is fairly light, but also strong. That is very true. Yeah. So it is compatible with body tissues. It is good strength. It has the ability to integrate very, very well with the bone. So that's why it is used a lot. And yeah, so the screws here, you find the screws they use, the plates they use, the best quality of them are all out of titanium. Yeah, so here you can see this titanium mesh. It's used to reconstruct the defect here in the skull. Yeah. So here on the floor, also you can use a mesh, and then you are able to correct. Because you see, you don't want to put too much weight here. Too much weight here is not good. It's going to destabilize the head. So it means the weight on this side of the head is going to be more than this side. Remember, God, the creator, he is a very good scientist. He was trying to balance things up. So you don't want to have a heavy head, which is going to fracture the spine. And you don't want to have this side heavier than that. So you want to use a thin mesh, and so that this side can be able to balance with that. Yeah. So those are the dynamics. And somebody asked, okay, what was that question? It was in the chat room. It was how do you reach? I think it was a very important question. How do you reach? Is that? It was about skinning and how internal fixation of the fracture of the skin is done. Do you first skin that part of the face? Yeah, I think I had answered your question. How did I answer your question? Yeah, I think there was here. Yes, this is one of the methods you can use also to reach here. The zygoma, you can open here and you are always going to be able to see the zygoma here. Or you use the intraoral approach. I'd shown for you another slide. During using the buccal sulcus, you can actually be able to reach that zygomatic arch. And yeah, so usually we use kind of a special kind of forceps which you use for lifting the fractured zygomatic bone. So if you want to do a actual open reduction, this is the technique. Open reduction with fixation. The other one is just it's not an open reduction, it's a closed reduction, but it is usually you have got to really be lucky, because sometimes there's relapse because the patient slips on it and then it falls back. Yeah, so mandibular fractures, yes, quite common. I've already shown for you some of them, and this is the fracture we saw. And also partly, you can see close here, we also have this, the foramen. Yeah? And then here we have the symphysis, then the body, and at the angle, you can see 20% of the fractures at the angle, and 3% on the ramus, and the coronate process, 3%. This part is a very notorious part for mandibular fractures, the neck, okay? The neck of the condylar process. Yeah. And it is common to have multiple fractures. And as I told you, we had that fracture here. And at the same time, you may have another fracture here. And at the same time, because that impact goes here, because you will have to see a fracture here, you see a fracture here, then there can be a fracture on this side. So when you are assessing those patients, please don't forget the, and this may be the reason why they cannot open and close the fracture in the neck of the condyle. Or sometimes it's a fracture to the angle here. Yeah, this is still the angle. And the fractures here are because of this teeth here. This is the root cause, this third molar teeth. And also here, the second reason is, you know, this ramus is thinner. It's thinner than the body of the what? Of the mandible itself. So, let me just, yeah. So I think now you have the answers here. When I ask sites of weakness, you already know. Third molar, socket of canine, condyle neck. So you should not fail these ones. This, I'm sure, since now the other guys chose to leave the class, these are going to be the exam questions. Let me, we also, fractures of the mandible, a key point about them is that they can either be favorable or unfavorable. Now, favorable means they're easy to reduce and fix. Unfavorable means it's just very hard to reduce them, particularly when you are using intermaxillary fixation, because the fractured end is pulled away, you know. Yeah, it's pulled away because of the muscles. And the muscles are listed here, the masseter, medial and lateral pterygoids, and the temporalis muscles. And so they will be pulling the fractured end away from the main body. So it makes it very unfavorable. Yeah. So the favorable fractures, that means if you just ask the patient to close the jaws into the occlusal plane, then the fracture line disappears. So it means it just a simple wiring will be able to reduce that and fix that fracture. But in the event of unfavorable fractures, the fractured end is pulled away. And so that is usually best managed with internal fixation. And in the event when there's no internal fixation, when you actually do just the simple intermaxillary fixations, that is usually the major root cause of non-union, non-healing, you know, things like that. Yeah, so these are just some of the, now here, you see this is a more favorable fracture at this point, yeah. So this medial pterygoid muscle has pulled it back and it is stable. So when you close and you're able to sometimes, actually, okay, maybe the disadvantage of this one, when it is a little bit more straight, is this is going to be hanging, because this, when you close, these ones can come up, but because you cannot wire on this one, it may stay a little bit down. But because this muscle is pulling it, it may survive. Yeah. Yeah, so these are some of the problematic fractures. Yeah, it's quite problematic. So this will go up, this will be hanging. Yeah. So so usually the favorable fracture would be fracture, which will be like this, so that when you pull this end up, it will also pull the bit which is there, like this one. This one has the potential of pulling this one up and stabilizing it. But when it's like this, then this one will pull away, this one will create a space, which will be a site of a non-union. Yeah, so this is important for you to appreciate, because then you'll be able to recommend that this person goes for internal fixation or stuff like that. So this you can always see on the X-ray. Even in your own examination, you can easily see this fracture is displaced. Yeah. So in the physio exam, when you palpate, if you can palpate and detect a step of, malformation, deformity, yeah, tenderness, malocclusion, trismus, normal opening, at least your 3 fingers, the 3 middle fingers, should be able to fit when you open the mouth. Yes? So if the 3 middle fingers cannot fit, then you can start thinking of trismus. For example, if only 2 or only one finger can fit, then that's already trismus. 2 fingers, trismus. 3 fingers only, that is what? Trismus. So then a sublingual hematoma, I think I've already talked about that before. And the altered sensations, creptus, even when they're opening the mouth and you can hear the TMJ, there's a lot of crepitations, then you know there's a problem. Yeah, so now here obvious fracture, here trismus. Yeah, it's trismus. You can see this is very, very limited opening. Yeah, this is an obvious fracture. Fractures of the condyle, lateral movement of the mandible becomes a problem. You can see that the mandible moves in an unequal manner. If you will ask a normal person to move their jaw, lower jaw, right and left. Then you just master that. And then the next time you ask a person to move their jaw, lower jaw, right and left, then you will see how the jaws move. You will sometimes see that the jaw is tilting on one side. One side of the jaw is tilting downwards, and the other side is a little bit up. So that is just visual observation and asking them to move the jaw right and left can give you a lot. So radiographs. I don't know if you guys have ever seen a panorex. Just those of you who are still in the chat room, just yes and no. Anybody familiar with panorex? No. Is there no, yes, no, yes? You are only 20 people? No, no, okay. Yes, so, but we actually have a panorex machine, but it's not installed. In the future, in Mulago, it is there, and in Kampala Imaging Center, they do have. So next time when you're in Kampala, you can actually, if you went to Mulago, you can actually understand what it is. Yeah. So it is, Panorex is very good for imaging the mandible. As you can see, yeah, this, what it can do, it gives a complete map of all the teeth, you know, the maxillary from molar to molar. Mandible, you can see that this guy doesn't have the what? The third molars here, yeah? Even here, they are not there, yeah? So, only has molar 1 and molar 2, molar 1 and molar 2. And then you can see that these maxillary molars, even their roots are not yet fully formed. So this is definitely a very young, relatively a younger person. But then you can see that the third molars are actually not here. So it means they were already removed. Yeah, they are removed. Yeah, they are. Otherwise, if they were not erupted, you will be seeing them here. So they are not here. So they are removed. But overall, you can see this is a young person. But again, you can see some metal piece here. So this means this person has been undergoing maybe orthodontic treatment. Yeah, because I can see a metal being bound. So, and on this Panorex, you can see the said, you know, this radiolucence here. This is where the nerve and the neurovascular bundle, which is coming from here, passes here. Yeah. Yeah. So sometimes this Panorex is very powerful because then when you are to do, sometimes there can be pathology. Yeah. You maybe a tumor and so on. And then you are able to see how far, how much of bone are you left with? Yeah? How much of the bone? Here, anyway, the cortical plate is there. It is intact. But you can see that there's some bit of radiolucence around this tooth. Yeah, so, and also the other advantage, you can be able to see where the ramus ends, so the TMJ, and so it's very powerful. So closed reduction, yes, this is what we usually do, as I already told you. And the conditions, that means the fracture has to be favorable. If favorable, I've already told you, it's non-displaced. The fracture is not grossly comminuted, okay? It also doesn't work when the bone is atrophic. And it is relatively not easy with the children, okay? Their teeth are just erupting and the other teeth are just falling off. It's really not the easiest thing to do. So, open reduction, of course, fracture is unfavorable. Fractures associated with midface, as I already showed for you. When the intermaxillary fixation is contraindicated, for patient comfort, Because you see, when you do open reduction, the patient will go back to doing their business almost immediately. Yeah, it reminds me of a kid who worked on some time back when we had some elective in German, and we worked on that kid like in the morning hour, and then in the evening we are going home. We found the guy riding on his bicycle, and my colleague was, isn't this the guy who was there in theater? It was like a shock. The guy is back on the bicycle, which had thrown him, and he had fractured his mandible. So, yeah, so those are the advantages. Yeah, and a lot more here, which I think you can read. Those are now. And the contraindications, yes. And also, yeah, so pay attention to these contraindications of the open reduction. It's really key. Yeah, maybe this one, let me just emphasize a few points here. Yeah, because the intermaxillary fixation is the commonest thing we actually do. You are likely to see those patients because you'll be managing maybe them on the ward. Then the issue with them, they will always start complaining, you see, I'm hungry. Can't you open a little bit so that I can eat? But there's no way. You guys know how long it takes for fractures to heal. So it is not just about I'm hungry. It's about understanding the science. So the condylar fractures, we don't want to keep them long because of fibrosis. Because when you keep them long, there is going to be fibrosis in the socket there, and then ankylosis will set in, and then failure to open the jaw. So you don't want to keep the fractures of the condyle long, particularly if we are doing intermaxillary fixation. It's not the best thing, but then the patient has to start opening the jaws. Otherwise, you are going to end up with the really big time complications. The fibrosis will set in, it will cause ankylosis, and which ankylosis will cause difficulty in opening the jaws. Yeah, so those are the issues. Yeah, so the rest, I think you can, yeah. So I think I needed to emphasize this, why, yeah, pediatrics also the same, it's the same reasoning. Yeah, these guys, their jaws are growing very, very, very quickly. And you don't hear for the pediatrics is because their jaws are growing very quickly. You know that. And so you don't want to fix them. Otherwise, you are going to distort the jaw growth. For the condyle, it's because of ankylosis. For the geriatrics, you know the healing is very slow. The jaw, the teeth have fallen off. The dental patients, you know, they have no teeth now. So you want to extend the time because the bone is even atrophic. So it takes long to heal. Yeah. So that is it. Okay, so here, yes. Here is the techniques we use for the intermaxillary fixation. These are what we call eyelet wires. Eye is this thing here. This is the eye. So it means you pull the double ends of these wires through the interdental space, and one piece you will pull it that way, it will pass that way, just like this one. So that means one side you pass it that way, the other side you pass it this way. So now this end, which is in the distal side, you will pass it through this eye, and then this one you pull it out, and then you tie them, then you curve them, you cut and then curve the end and hide it here so that it avoids trauma. So it will look something like this. So this is the end which has been tightened and cut, sewed, and fixed here. So this is how it looks like. So if you are good, you can actually practice and learn how to do this. Yeah. So you first fix these eyelet wires, then you now come and join the lower ones with the upper ones. So to join the lower ones, you will fix again now like this one already has here. So it means you will fix another wire through here, and you pass it through another eyelet on the opposing jaw at the same level, so that you pull them direct, and then you reduce and fix, and you tighten them, and you already know how long you're supposed to leave them in space. So this is a cast. Okay. So I'm not going to emphasize this. This is how the plates look like. This, I think this I've already. Yeah, so now those are just the different. Yeah, so I think you can read the rest actually now, because so yeah, because I think I've already really talked about these things, so it's just the details. So are there any questions? Do you have any questions? Questions? You can.
I think there are no questions, Doctor.
Okay. So if there are no questions, I know it was quite long and a lot. There's a question. One, thank you. Yes. So the question is in the chat room. It is
Yes.
that aren't the eyelet wires hard? I see a risk for trauma. Okay, those eyelet, the wires, the surgical wires come in different gauges. The one we use for doing this, if the gauge is bigger, it is usually, it has the disadvantage. Okay, they come in different tensile strengths. Some are very rigid and others are really soft. And if the gauge is bigger, then you find that it is going to traumatize the interdental spaces. But the one which we use, it can be like 0.4 millimeters, 0.35. Yeah. So the smaller ones again tend to be too fragile and they tear easily. And then the one we actually use most times is the 0.4 millimeter. And when it is the right type, they are really soft, but they are very strong. They don't tear easily, those things. The advantage with them also, the tissue doesn't reject them. So sometimes you can even leave them there for a very long time and they will not cause any harm. But of course, we have to remove them because they may not look good. And yeah, so yeah. So, and besides, when the bone has healed, why leave something which is foreign there? So we remove them. Yeah. So yeah, trauma as such, I will say relatively no, they won't, unless if you apply them wrongly. If you apply them wrongly, let me go back to just the slide which was showing. Yes. So this, okay. Unfortunately, on this slide, it is not showing the mucosa, yeah? But you know that it is mucosa. And so we don't put this thing on the mucosa, never, never. You don't do it in the mucosa. You remember the structure of the tooth around the cervical region. There is usually that depression on the tooth. You know, from the crown, there is the neck, and then it goes to the roots. And so just at the edge, because usually what you do, because you remember there's this attachment, the gingival attachment to this part, there's this space, yeah, the gingival sulcus. So we usually do these things and you even fix them just below. You don't want to traumatize the gingiva because that would be disastrous. That is going to create a cascade of trouble. Because you traumatize the gingiva, then the gingiva is going to become necrotic, then you are going to expose the roots, and then you are going to cause other problems. So you never do that. So when you fix this thing, you are going to fix it in the intragingival space below the whatever, the gingiva. Actually, even you will not be seeing them here. You will not be seeing these parts which are outside on this side, because somehow of this part, it may not be totally feasible to fix them below, but you leave them just at the edge of the gingiva. Yeah, so that's how it is. So you have to minimize any trauma, because the trauma is going to sustain the problem. Yeah, so I hope I've answered that question. Another question, Doctor, when there is mandibular fracture, okay, when the mandibular fracture is unilateral, do you have to wire the opposite normal side as well? Yes, you must wire the normal side. That actually is bonus, because it is the normal side. You remember, once you reduce the abnormal side, which is fractured, to the level of the normal side, then that means you will achieve normal occlusion. Then even the normal side helps you to stabilize. So it enhances the fixation. So yeah, that is it. You fix everything. How about activities like brushing? Yes, you must brush, because you can brush, you can rinse them off. Then they should feed on liquids, like in mast, potatoes, yogurt, milk, porridge. Yeah, things which can be drunk, soup. You can make for them fish, you know, which is proper, like this fresh fish, which is softly cooked. Then you make it into soup and they drink. They will be okay, actually. They will be nutritional. Okay. Another question. Oh, yes. Okay. Yeah. So this other question was, so the activities of the oral hygiene, like brushing, won't they dislodge these things? My brother Nathan, okay, my young brother, maybe son, I can assure you, these things, the way you have seen them fixed, because remember you, okay, let me first remove the, yeah, the way you fix it, you remember you are fixing it in that dental space down, and you are going to turn it. This will pass there. This other end will pass here. And then you are going to tie them. You will pass this other end through this eyelet, and you are going to tie them very, very, very tightly. These things, you tighten them really, really tight. So when it gets dislodged, then it is a sign that it was not done well. So when it is done well, it should not be dislodged. Yeah, once in a while, all these things can be dislodged for two reasons. Okay, about three reasons. Reason number one, You over tightened, it is torn. So obviously it is good. You might have not realized it by the time you leave the process, then it is torn, then it's going to become loose, it will get dislodged. Then two, it's obvious that you didn't do it well, so it was already loose from the beginning. Then three, another reason is the tooth on which you anchored it became loose. Maybe it was already involved in the fracture line, then it becomes loose, then it loses that grip. So yeah, those can be the three reasons why it can be dislodged. But otherwise, if you choose the right teeth, which many times organ fractures can happen, unless in very severe trauma where there are multiple teeth which are involved, then you really find it very hard to get firm teeth to anchor these things on. Yeah, but otherwise, when the teeth are not over disturbed, then they should be really, really firm. Yeah. So, yeah, good. I can see there are now no new questions. So I can now say that thank you everyone for having been good students. And you remind your friends that there are going to definitely be questions from this presentation. Mr. Paddy.
Yes, doctor.
What you are going to do? Can you email me now and remind me with just your email so that I send this slide to you right away and you share with them, because then they should have no excuse for that we didn't receive the slide. I know
Okay,
they can
doctor.
say, they can tell us that, you see, like me also, that the internet was not there, you know what and what. But now after this, they will access it at their own time and they must read, because when the exams come, there should be no what? No excuse.
Excuse.
Yes, no excuse.
Doctor,
So,
please write your email.
WARU.
Yes.
Yeah, you know, RUBAKU@mass.ac.ug.
Okay, doctor.
Okay, so next week, same time, we have another lecture. We are going to be looking at those habits and so on and so on. Yeah?
Okay, doctor.
Oh, okay, so you remind them, they must not dodge that class this time.
Okay, doctor. Thank you so much.
Okay, welcome.